Welcome, everybody. So I'm going to start an introduction and then I will hand it to Patty in just a minute. I'm Mara Yale. I co-chair the parent board for the Mass General Hospital Pediatric Stroke Program. And we've been running educational events since 2019. We hosted 2 in person in 2019. And then in the season from 2020 to 2021, we hosted 10 online. This is our second in the season going from 2021 into 2022. And we're very excited to have a whole lineup of events planned into next spring. So today's topic is the first of 2 sessions on the topic of feeding, and that there's a lot more complexity in feeding than one might initially think. And Brian, if you're available, what we're going to do is have you introduce Tricia. So we have, as usual, we have a parent who's planning to share their story, and then an expert. I'm just checking with Brian. Patty's in transit. Julia, I'm going to mute you. So it looks like neither Patty nor Brian can speak right now. So I will just say that I'm honored and excited to welcome Tricia, who's a mom to a 6-year-old, and she will tell her family's story, and then we'll hand it over to Susan. And I just want to remind all of you that this is part 1 of a 2-part series on feeding. So if this topic interests you, please come back again next month on November 19th. And as usual, we will be posting the recordings to our YouTube. It does take us some time to post them, so stay tuned. Tricia, welcome.
Hi. So my son Will is 6. In 2017, October 5th, I put my perfectly healthy 2.7-year-old to bed at 10 o'clock at night, and at 1 a.m. he woke up screaming and vomiting. We couldn't get him to open his eyes, and we were taken by ambulance to Hasbro Children's Hospital. They discovered that he had an AVM rupture and brain bleed. And he was rushed up to the PICU where they drilled a hole in his skull to help relieve the pressure. And they put him in a coma for 11 days in an effort to keep the brain swelling down. They were not confident that he was going to survive, but he's a warrior, and he did. So we were at Hasbro for about a month. When he was out of a coma, we discovered he had right hemiparesis. His injury is a left frontal lobe injury. And he was not able to talk, sit, walk, crawl, all of the things that he had previously been doing. We were moved over to Spalding Rehab for 6 weeks from Hasbro, and he made huge physical gains there. He was talking, not clearly, but he had regained speech, and he was, during that 6 weeks, able to sit by himself, crawl, stand, and eventually walk before we left. While we were there, however, we also noticed he had sensory issues, which he had never had before, the most obvious of which being a lot of noises were bothering him, and we ended up getting him some earmuffs, which was completely foreign to me at the time because, you know, we'd never had any issues like that. He also became really picky. You know, you get to choose off the menus at these hospitals, and Will had been a kid who loved everything, but he was only choosing 1 or 2 things, and he was not eating things that he had liked before. But we were in a hospital, and he was a sick kid recovering. No big deal. Kids get picky, you know. So in the spring of 2018, we found out that we needed to have Will's AVM removed, which would require brain surgery. So he had a craniotomy in August of 2018 to remove his AVM. It looked like they got it all. He had to recover from that, obviously, and his physical recovery was pretty good. He had a lot more sensory issues. He was becoming more rigid, and his need for control was more obvious. He was eliminating foods that he loved, even things that he would eat every day. Suddenly he would say, I'm not going to eat that anymore. And then he would actually never eat it again. And he also clearly had some medical trauma. We went back to, as soon as we got out of Spalding, we got into outpatient therapies at Hasbro Rehab, and we were continuing with those. But he was starting to have social issues around food. Like, we would go with his friends to McDonald's Play Place, and they would all have lunch, but Will couldn't eat there because there's nothing that is acceptable on the menu. And so I was becoming concerned about that. In spring of 2019, we discovered that Will's AVM was regrowing, and he was going to require another surgery. So in September of 2019, and so this is just under 2 years from the original event, he's going in for his second brain surgery. We know that he already has medical trauma, so we sought out a therapist for him to help us work on that medical trauma. Because we were in a hurry to get somebody, from the time we found out he was going to need the second surgery, we couldn't get in with any of the typical therapists. So somebody referred us over to somebody who did medical, behavioral, and therapy. We saw her during that summer, and she felt that Will did not have any medical trauma, but that he had a lot of behavioral issues around food and toileting. So she said that she was going to get us into a program after Will's surgery to work on that, so that we could, get that going. So Will had a surgery in September of 2019. And then in October of 2019, we started a month-long program, which could be extended at Bradley Hospital. It's a behavioral program, day program for kids. It's drop off, but you can stay. I stayed, and I didn't feel like Will was getting a lot out of it. And in exchange for going to this program, we had to give up his OT, his speech, his PT, and he had to stop going to his inclusion preschool, where he was also receiving all of these therapies. 2 weeks into this program that I dreaded daily, we had our stroke clinic appointment with Dr. Mussolino at MGH. And I was telling her that, we were only halfway through this program, and it didn't seem to be helping a lot. And it was very stressful for me, so I could only imagine how it felt for Will. And she told me that I can tell doctors no, which is something that had never occurred to me. We had been a medical family for 2 years, and my son was saved by these people. Like, we were so lucky to have him. If a doctor told me to take my son to a bridge and we should jump, I was going to do it. There was no questioning anything that a medical professional said to me. And she said, she agreed that this wasn't the right setting for Will, that his brain was healing, that he needed to be in his therapies, that he needed to be in school, that those were the places that were actually going to help him heal, and that this was as terrible a setting as I could have put him in. And so we got out immediately, but that was a huge power for me, because that was the first time that now I know that if something feels wrong, I can say no, and I would never have done that. So we left that, and we got back to all of our important things that we were working on. Will's eating was still a really big issue in our house, and a big issue with friends because, you know, he was eliminating snacks, he was eliminating candy. I mean, the things he was eliminating was not just, you know, I don't eat vegetables anymore. And so we were talking with his speech therapist about it, and she referred us over to a colleague who would do a swallow study and start some speech therapy for him. I'm sorry, some feeding therapy for him. The swallow study was fine, and we did feeding therapy for a few weeks. Will hated it. It was going nowhere. I couldn't get him to work on it at home. And she said that she felt like when I told her that she felt like she wasn't getting anywhere either. And that what he really needed was to see feeding team over at Hasbro Hospital. The feeding team consists of a gastroenterologist, a nurse practitioner, a child psychologist, an OT, a speech pathologist, and a dietitian. So they all evaluated Will together. And then Will's team became the child psychologist and the OT. And we met with them weekly, and they did a lot of food play with Will to get him used to being around food and experiencing food without necessarily the expectation of eating it. We also learned to do food play at home, and they had to start doing something called tasting time where we would try different foods. And Will was making gains that you could not see. They were so small. My husband didn't go to therapy with us, and he couldn't see it. He kept telling me, no, there's nothing changing. And I'm like, no, you don't understand. There is. Here, they explained it to me. Look at this. And they're so insignificant that it feels like you're going nowhere at first. We started to make a little bit of a gain, and then they did something called food chaining. Food chaining is like if your kid will eat a chicken nugget, then they'll put a piece of chicken on the plate. Because it's similar foods and you're trying to get your kid to expand out. Will was infuriated by food chaining, and we lost all the progress that we had made. He stopped trying anything, and we had to start from scratch. But our team was amazing, and they started a new system with a social story for Will. The social story consisted of 2 foods that I would choose, and then Will could pick which food he was going to taste at tasting time. The story included 2 choices. So I would say, you know, you can lick or bite this food, or you can smell or touch this food, and he would get to choose which one. So he was in control. And he got to roll a die to see how many times he was going to do this thing. This worked amazing for us. Will did a great job, and we are still doing this now. We've been with feeding team for a little over a year this summer, and we are down to once a month now, but we finally are seeing a measurable goal. We were able to pack a lunch for Will. There's something that I can put in a lunchbox and take with us. And that is a significant move for us because now we go to a co-op, he can eat there, which was a problem. I didn't know what I was going to do. So I think that you know, we're nowhere near done with our journey, but we have a light at the end of the tunnel. Once you see that move, it feels so good. My kid this summer was like, can I try your ice cream? And that was not something that would have ever happened before. He's interested at the corn maze. He said, I'd like to try corn on the cob for a tasting time food. So because he's in control now, which is so important to him, he is making his own choices, and he feels like he's in control of the food choices, even as he's expanding. And that's everything for us. Thank you.
Amazing. And thank you so much, Tricia, for sharing this compelling journey. I know from looking at the people that are here in our talk, and also I know a lot of people are going to watch it after hours when they are able to do it, that have signed up for the series. There's a lot of kids and parents here that have had the stroke or the brain injury early in life. And what I find so enlightening of the story that you're telling, with all the intricacies that our expert, Susan Summers, is going to cover in her talk. So I'm not going to talk about the specifics, but what I find very compelling is the ability that you had of knowing what was different, which is not something that a lot of parents that have a baby that is in development are going to be able to have to compare. And what I think is very important to keep in mind and for people to ask questions is this aspect of a behavior arising instead of a clear, oh, it's having problem with chewing, which is what we tend to think when we think about eating. And also the fact that the meals and the table is so much of family life and growing up and being a kid and being a parent that it cannot be minimized. So with that, I'm gonna thank you again. Thank you for sharing it. There's gonna be 2 parts of the series, as you guys heard. I'm gonna pass it on to Suzanne. Suzanne, thank you so much for taking us on. And I hope we can have a wonderful Q&A session. So I'll see you guys in a little bit.
All right, I'm gonna share. Thank you for having me. I'm gonna clear that out, I hope. There we go. My name's Susan Summers. I am a speech and language pathologist, clinical supervisor at Spalding Outpatient Center for Children in Salem, Massachusetts. And I have just found feeding therapy and feeding evaluation to be my passion. I've worked with kids on, as we'll see, all ends of that feeding spectrum. Found that the behavioral kids really fascinate me. I've received anxiety certified rehabilitation services provider training as a little extra because I found so many of these kids have anxiety related to their feeding. I'm going to let Kate introduce my sidekick here.
Thank you so much. As Susan said, it is a pleasure to join you guys today. Thank you so much for having us. My name is Katemundo. I'm a pediatric occupational therapist, and I have the privilege of working with Susan over at the Spalding Outpatient Center in Salem, Massachusetts. And Susan and I actually act here on the pediatric feeding team. So we have our own pediatric feeding team where we get to see a myriad of children, some who are coming through with different medical diagnoses, including some that have had some strokes and neurological insults. So I'm going to turn this back over to Susan. I'll periodically jump in throughout this discussion and dialogue, and you guys will hear more from me in part 2. So I look forward to seeing you guys then.
I just want to go over a few terms. I mean, with feeding, we think of the term dysphagia, which is really just a difficulty in swallowing. Kids, adults with neurological impairment, I think everyone's first thought is it's that swallowing impairment. It's that abnormality in swallowing, trouble chewing, trouble initiating a swallow, aspiration, things getting stuck, esophageal reflux. But with pediatrics, we also define it as feeding impairments as well. So we look at both sides, and I think Will is, such a great representation of that other half of the feeding kids we see. There's that food selectivity, I'll only eat one thing. I liked it yesterday, I don't like it today. I'll only eat it if it's in a blue bowl with ice cream on top. There's those sensory difficulties, it's too hot, it's too slimy, it's too crunchy. We also looked with the feeding impairment postural and positioning needs, which we know, a lot of our kids who have stroke have different motor needs and supports they need. And then we look at the behavioral difficulties. So, and a lot of the behaviors, as I'll be talking, come out of all of the above. So, I kind of represented, this is our feeding, and the swallowing is that more mechanical part of it all. When we think of pediatric dysphagia, again, feeding and swallowing problems can be secondary to or impacted by our medical issues. And with the stroke kids, be it perinatal, neonatal, childhood onset, we're going to see different things. No 2 kids are alike, and then no 2 traumas are alike. And so where those trauma occurred, where the bleed or the clot might have occurred, when it occurred in terms of the child's development, how large and pervasive it was, that all impacts what we're going to see as their characteristics. We also think about medical issues, and Kate knows I'm really big on this, is those GI issues. They really impact the kids. There's allergic reactions, there's reflux, there's constipation, and the kids learn really early, it hurts to eat. And it's amazing how that carries through with the kids. We also have to think about medical being surgeries, being their medications. Enlarged tonsils plays a huge part at times. You know, if I'm going to eat a chip and it scratches those big balls in the back of my throat, I'm never eating that chip again. So we really have to think of some of those. Also, respiratory, pulmonary issues. With our infants, we have to think of the coordination issues for the suck, swallow, breathe. We also look at the motor and oral motor challenges. So are there any structural anomalies? We look at the child's tone. We look at their ability. Is there a hemiparesis that's going to impact their ability to manage a bolus, be it liquid or solid? Sensory issues. We talk about hyposensitivity or low awareness. Those are those kids who are those stuffers. We talk about the hypersensitive kids who you can't even get something in their mouth. And we also see the mixed kids who have some hypo and hypersensitivity. Vision and auditory impairments also impact feeding. You know, we need to be able to see what's in our plate. If we're hypersensitive and that crunching of a chip is really loud, that's going to be annoying to us. Also in terms of using behaviors, the avoidance, the refusals, the anxiety, structures and limits, distractions versus reinforcements. And I think, as Tricia was mentioned, those social factors. And, you know, sometimes too with the older kids, there's a frustration of what they've lost. And so that impacts their wanting to get out and go eat with friends when they're able to do so. So those are some of the things we have to think about in terms of that. We also think about the child's feeding history. So were they breast bottle fed, NG or G tube fed, or any combination thereof? We like to look at any issues they had early on with latching, sucking, or swallowing, you know, and what is contributing to those difficulties. Are they desaturating with feeding, as mostly with our infants? We also want to consider, did they need multiple nipple changes, formula changes? Is there that allergy going on there, or that food sensitivity? We want to see how they coordinate that suck, swallow, and breathe. And then introduction of solids, how'd that go? With Will, it went really well, and then it became a problem later on. So we want to see how those textures and their responses went. And a restricted diet wasn't always an issue, or is it new? And are they refusing previously accepted foods? We also have to consider the trauma. I mean, everyone's been through so much trauma. The kids have been through trauma. The families have been through trauma. And we want to think about different trauma-related issues. Medical diagnosis and treatment with our kids. We have the needle sticks. We have different tests, the MRIs, the CAT scans. We have the hospital stays and visits, gagging and choking, vomiting, be it from medication or be it from just reflux or be it from aspiration. And all the tubes some of these kids have had to have, the NG tubes and the G tubes and the IV tubes. So they've been through a lot. The families have definitely been through a lot as well. For some, it's the breastfeeding journey. For some, it's trying to figure out what kind of nipples work with their kids. There's that food security. Can we really get the right foods for our kid? They also need to be watching your kid in pain is really a traumatic event as well. So we have to think about that. There are high impact traumatic events such as natural disasters, car accidents, for some of our kids being stuck in COVID. So some high impact events. And our child has feelings of fear, pain, anxiety, and distress. Some forced feeding, because, you know, we all want to get our kids to eat, and sometimes we all get desperate. Feelings of being burdensome. And then prenatal care, exposure to stress, drugs, alcohol, and utero. So there's a lot of trauma that goes on in different ways with our kids. We take all of the above and we have to consider the behaviors that emerge. But we also have to remember behavior is communication. That's my speech part here. the child's trying to exert control because they don't have a lot of it. And so we really have to look at those behaviors and realize what the child's trying to tell us. I've added this slide here. I moved that slide. We want to look at the kids with a trauma lens. So what we see here, we might see fear of anything new or unfamiliar. We might see rigid mealtime routines, food refusals, spitting out food, gagging, vomiting, turning away, leaving the table, restricted variety, jag eating. I'll eat macaroni and cheese every day for 3 months, and then I'm never eating it again for another 5 months, and texture difficulties. But then if we look at it through a trauma-informed lens, we might say, you know, are they trying to assert control or autonomy? Are they telling us they're uncomfortable and pain? You know, if I have parents who say, well, they won't drink orange juice. Well, they have reflux. They've learned orange juice is uncomfortable. I'm not going to eat it. So are they trying to tell us something in a different way? Do we have unresolved medical issues? Any other diagnoses? Are they self-protecting? Do they feel pressure to eat? Do they really lack the oral motor skills to eat what we're presenting to them? Their dysregulated sensory systems. Are they having anxiety and fear around eating? And any type of aggressive feeding practice and impact of the environment and their routine. So we really want to look at what the trauma is, what the behaviors are telling us. So indications for referral would be, and again, we're kind of looking at it as that oral motor, neurological impact, dysphagia. Are we seeing problems? I got a little technical in the oral preparatory stage. So when we're taking the food in, are we problems orienting the food, taking it in our mouth, containing it in our mouth, chewing it up and transporting it back to swallow it? Are we having trouble initiating a swallow? Are we having trouble once it gets down here in our throat? You know, is it going down the wrong pipe, so to speak? And that will lead to aspiration. And, you know, we have to think about, again, that damage to the brain and what it's impacted, the cranial nerves that it might have impacted as well. And is that impacting the musculature for a safe swallow? And then we also have to think, once it gets into our esophagus, is it moving smoothly into our stomach? Poor coordination of that suck, swallow, breathe that an infant needs to successfully eat. Irritability, respiratory effort, fatigue, weak suck seal, coughing with an infant feeding. Again, that reflux and vomiting and GI issues. The eosinophilic esophagitis is an allergic reaction that causes inflammation in the esophagus. Respiratory and pulmonary issues or pneumonias are a big red flag for some of our kids. Oral motor problems and acquisition of the skills you need or dysfunction for effectively chewing and swallowing. How are we transitioning some of our kids from those tube feedings? You know, and a lot of families need help with that transition. Delay in development of self-feeding skills and failure to thrive or a lack of adequate weight gain. Other indications on that away from that swallowing issue or feeding issue, they accept little or no food by mouth in absence of a medical issue. Poor hydration, volume limiting, only will take 3 ounces. Restricted diet and extreme food selectivity, failure to advance the textures, behavioral problems related to meal times, gagging and crying, spitting, vomiting, throwing foods. All of these things are some of the things we see in our kids. Mealtime behaviors, can they sit at the table? Are they grazers? Are they leaving the table? Do they need a distraction to eat? So those are some of those other red flags. And then we get into our sensory kids. They can run the gamut. We have our hypersensory kids, our kids with reduced awareness of the stimuli. They have a heightened sensory threshold. Those are the kids I call our spicy kids. They need that extra sensory input to know where the food is in their mouth. And Kate's going to get into that in our next session. But they can be seen with poor sucking, liquid pooling, gagging, overstuffing, and pocketing, where they just kind of hold that food in their mouth for a while. Hypersensitivity, heightened awareness of stimuli in the mouth, decreased sensory threshold to oral input, but can be seen in a heightened gag, tongue bunching. When you try to get that spoon in there, that tongue just blocks it from getting in. Refusals of food and reduced progression to textures. I've found, as a side, you know, if I work on desensitizing that gag on our kids, we make so much progress because they really don't want you in their mouth. I've added this as reference points, and I'm not going to get into it in detail, but I think it makes a really nice point about the motor skill development and its relation to feeding. You know, we want to make sure that kids, you know, can sit upright, can manage their torso so they can focus on their mouth. And we really always say we like a nice 90, 90, 90. And I love this picture. He's sitting upright, his knees are out, his legs are down, his feet are well supported. And that's really important for that support for feeding, because you really need to have that support in your torso so you can really think about those oral motor skills. And some of our kids might need that extra support. You know, do we roll up towels? Do we put them in different adaptive seating? You know, a rift and feeding chair, a tumble form chair, you know, something to give them that extra support so they're not working so hard and being a little wiggly.
And Susan, can I chime in real quick? I think I love how you put down these are reference points, because we always want to think it's so, I feel as a parent, it's so easy to get caught up in the number game. And so what I mean by that is solid foods get introduced to this timeline and child should sit at this age grouping. And so when we think about feeding, we really want to think about how our bodies support the act of eating. And so as Susan was mentioning, we love that well-supported infant and toddler where their hips are really well supported, their knees and their feet are well supported, because if not, if they don't have the trunk control to sit up, it's very hard to actually be able to isolate and use the muscles around your chin and your cheeks and your jaws to do all that active chewing that you want to do to manage safely some solid foods if you don't have the trunk control and preparatory skills for it. And so that's why we kind of look at those reference points versus those ages.
Yeah. You know, here it talks about baby-led weaning. I'm a developmentalist, so I'm not going to get into that. But I think we do want to see where the child is in terms of the development of their motor and oral motor skills. So what are some of our assessment options? We have instrumental and radiology studies. So you can call it by whatever name you want, a video fluoroscopy swallow study, a modified barium swallow. We have upper and lower GIs looking from kind of here to here versus the intestines and, you know, the emptying of your stomach once it's down there is our lower GI. X-rays, you know, if the child's constipated, you know, an X-ray is just an easy way to see what's going on. Endoscopies, where we're really checking the status of the esophagus so we can see if there's inflammation, we can determine if there's been reflux or that EOE. Gastric emptying studies, you know, how quickly are the kids' stomachs emptying? You know, is that contributing them to not wanting to eat and volume limiting? The pH probe, that's the little probe that goes in your nose and into your stomach and monitors your reflux. Fiber endoscope evaluation of swallowing, again, a tube that goes down and really watches the function of the swallow and, you know, are your vocal cords closing? Are you getting all the protective mechanisms you need for a safe swallow to avoid aspiration? And it's a real-time study, which is always nice. Clinical evaluations. Feeding professionals can be seen individually or part of a team. It sounded like Tricia had a fabulous team with occupational therapy, speech language therapy, dentistry, GI, ENT, nutritionists, physicians, and psychologists. So any combination of those professionals are just really helpful in looking at all aspects of the child. So I always like to say the feeding's the tip of the iceberg. I mean, again, it's like the behavior. The child is telling us there's other things going on, you know, or things going on with their muscles, their senses, their learning style, their capacity to eat, their developmental milestones, the environment, the nutrition, the things we're feeding them. And the problems may change over time. And so we need to explore everything we've just stated and evaluate what may be maintaining the problem. You know, the child with reflux as a baby may now be refusing foods because they learned feeding hurts. Early contributors have led to new reasons for sustaining the problems. And, you know, as we said, it's a combination of the factors. So what's treatment going to look at? All the things we just talked about. Treatment's multifaceted. We have to look at the whole child and their environment. And we really like to look at those medical issues first because we want to make sure the child feels good when they're eating. So we'll often look at their reflux, constipation, diarrhea, tonsils, dysphagia. You know, are we transitioning from tube to oral? Feeding's not comfortable, the kid's not going to want to eat. We look at those oral motor challenges. You know, is there an asymmetry? Can we not get the tongue to the side when we chew? We want to take a bite, move the food from side to side. If we have a hemi, we can't always get to that side, and really it might go down before it's properly chewed and aspirate, and that could just be all she wrote, and the kids get a little anxious at that point. So we want to look at their oral motor abilities. We want to look at their gross motor abilities, like we said, with that great positioning support. We want to look at the food properties that we're giving the kids. We want to consider the texture, the taste, the viscosity, how thick it is, the temperature, and even the quantity that we're offering at one time. With infants, we want to consider the rate of flow of that and look at different nipples and management as well as positioning while we're feeding those infants. With the sensory issues, we want to be aware of those tactile sensitivities in the oral and the hyposensitivities. Behaviors, they can arise from anything, and we must address all those components. We want the kids to feel safe, and that's what I always say in a first session. I just want the kids to trust me. They need to feel safe, and we want to extinguish any negative responses and reward all the positive responses. Slow steps, as Tricia acknowledged, it's a slow course, but every little step is wonderful. And then social and environmental factors involving the family to support change, looking at those mealtime behaviors, using schedules, looking at responses, and also considering the trauma the child and the family's been through. We also want to take nutrition into mind. We want to look at their dietary intake and growth and manage our treatment plan according to that. With growth, we want to look at their weight, their height, their weight for length. We want to make sure they're getting adequate calories, protein, calcium, vitamins, and liquid intake, especially for our kids with constipation. Primary nutrition, the first year is formula and breast milk. And so we really encourage parents not to worry so much about what they're taking at that, just getting those experiences. Any dietary restrictions, allergies, you know, allergies are huge because it's really going to impact their feeling of comfort as well. Any supplements we might need to provide to the child in terms of calorie enhancements, vitamin supplements. So once we do an eval, what might we recommend? Definitely that medical intervention, you know, that GI referral, that ENT referral to make sure the child's going to be safe and comfortable for eating. Direct feeding therapy may be warranted, or maybe just starting with a home program. Referral to other specialists in addition to the medical, such as the counseling, the GI, the dentist. Any nutritional changes, diet and calorie additives. Strategies for increasing acceptance, and I'm going to talk about that a little today, and Kate will get that more into that next time. Everything we do is subtle changes to textures and tastes. Any postural positioning changes we need to recommend. Cue-based feeding. we really need to go off of the child's cues and read from the child's. It's kind of that trauma lens. Behavior management techniques and development of oral motor skills, we want to make sure is there. With our kids who are more motor based with dysphagia and are swallowing impairments, we might use a variety of oral exercises, facial massage, tongue, lip, and jaw exercises to strengthen the muscles. We also will work with different food textures and temperatures to increase oral awareness during eating or swallowing and help to desensitize those oral hypersensitivities. And we also want to look at fine motor problems because we want to work on self-feeding and use of utensils and make any modifications we need to make to help the kids be successful in their self-feeding. I wanted to add this, especially for all the families that are, have been in the hospital and have gone through those swallow studies, because this is new. I know Mass General Brigham went live with this ITSE. I don't know if families have heard of it, the International Dysphagia Diet Standardization Initiative. I know we went live in February of 21. And so it's just a way of providing safety through common terminology for all ages. So it's consistency. This is an international effort. The ITSE.com website is full of information and it's in 17 different languages. So that's really, really wonderful and helpful. I mean, some families are familiar with the old description, especially for those kids who have a history of aspiration. Thin liquids, nectar thick, honey thick. Now in ITSE, we call them zero. We numbered them with drinks and with solid foods. So it's just something to be familiar with in terms of terminology you might hear. I've started putting together a parent handbook with ideas of how you, from the ITSE.com, how you test for each of these, but also ideas of foods at each level. I'm always happy to share. It's a work in progress. So what are things we can do to help our kids? We have to acknowledge our own fears, what's out of our control. Ultimately, our child going to eat what they're going to eat. The division of responsibility, and I think Tricia put it really nicely. The parent's role is on Saturday, what is served, when a meal or snack is eaten, and where it's eaten. But really, the child is going to tell you how much they're going to eat or if it's eaten at all. And I know that can be stressful. I had a kid who had some feeding difficulties, and it's hard work. We work to manage our own reactions and set reasonable expectation. We have to support the child's autonomy and create a safe, appropriate environment. And again, really reading our kids' cues. And the kids have anxiety. Food's scary for some of them. And so we really want to remember, don't feed the monster. Let's not feed that anxiety monster. Anxiety requires two things. Certainty, I have to know what's going to happen next, and I want to control it, and comfort. I want to feel safe and comfortable, or else I want out. So anxiety kind of wants to know everything all the time, or else we're going to avoid it. And anxiety is about avoidance. So we don't want that to thrive. It's best not to feed the monster. We want to reduce the avoidance behaviors to have the anxiety monster die a natural death. We're not trying to get rid of the anxiety, but we are trying to have better ways to address that uncertainty. Anxiety is going to show up, and when it does, we want to teach the kids how you're going to manage it. We don't want everything to be external. We really want to be internal. And I loved hearing, that Will said, I think I'm going to try that today. All of a sudden it went from us offering him the corn to him saying, I want to try that corn. And that's really the goal. We really want to say it's not either or. Do you want it or do you not want it? But how you're going to choose it, how they're going to interact with it, and let the child be the problem solver. So here are some ways we help to create problem solvers. And, you know, I used the term problem solver, and it was really appropriate to where Will's bleed occurred, because it was that frontal lobe and frontal, which really is impacted by problem solving. So we do a lot of different things. I love visuals for kids who benefit from them. We do follow that sensory hierarchy, you know, so can we tolerate it on our plate? Can we touch it? Can we smell it? Can we lick it? Can we bite it? Can we chew it? Can we swallow it? But this, I like giving the kids the choice. And, you know, within therapy, I might start with just presenting 3 of these. And then once they've mastered those, you go on. You know, some of the kids go, I think I'll just smell it today. And you're like, nah, you're good at smelling. We're going to move on now. But this really gives them that visual and that support that it's okay. I encourage parents to take these to restaurants. So the child has that choice when the food comes of what to do with it. And it's in the restaurant, it's not a big argument. They know, they feel safe that someone might not make them swallow it. We also use some rating scales and descriptions. I know this is really small and hard to read, but I have on my wall the yum chart, and it's little, super yuck. No, don't even like it a little. Hey, we're all allowed not to like something. A little bit yuck. It's not great, but I can tolerate it. It's okay, good, I like it. It's yum, delicious, I like it a lot. Or super yum, I love it big time. And it's really funny how the kids just really gravitate to this. They love showing me what they think of food. For some of my older kids, I think of how much will I like it and how much I really like it. So we take a vote with a little sticker where it is, and then how much we really like it. And it's so rewarding to them when they see, oh, it really wasn't that bad. I liked it more than I thought. Descriptions. I really, really love to work on descriptions versus that yes, no. Do you like it? I try very hard not to ask them that because they could say no. But I like to say, oh, well, it sounded really crunchy. Did you think it was crunchy? And it really just takes that whole focus away over, I don't like it and I don't eat it. The zones of regulation, I think is really great for some kids because we talk about how we're feeling today and, oh, we see calm. And then, you know, you present something, you take out that peanut butter they might not like, and they're getting a little wiggly, you know, and you put it on the kids. None of these is wrong, but it's just how we're going to get back to green. And so we always ask the kids, oh, you look like you're getting a little nervous. How can we get back to green? What we do? And the kid might say, well, I think I'm just going to lick it. I'm like, great, we're going to lick it. We're going to get back to green. You know, sometimes too, just having kids take that extra deep breath, you know, there's the mindfulness techniques people use. There's some rhythmic and movement activities that might get kids a little more settled before treatment session. So those are some of the little tricks we use. Other things we do, especially with that oral motor desensitization, you know, there are the jigglers where we give the kids the opportunity. We never go right for the mouth. You want to kind of start far at their extremities and see what they tolerate, from their hands to their arms, to their chest, to their cheeks. Turn it off. See how they tolerate once you turn on the vibration. The Z-Vibe is another tool we can brush our teeth, we can hop on our tongue. We use hospital touthettes as well. Other static tools, the Nook brush is something, again, we can just work on brushing our teeth, our mouth, our tongue. There's all kinds of chewy tubes to work on chewing, but also to introducing flavor. You know, maybe if a child loves to chew, we just dip it in the water to start with. And then we might flavor the water a little and present it on one of these tubes. I'm pleased to say one of my Spalding colleagues has developed the side biter, and it's really been awesome. There are 3 involved, and it allows the child to just chew, chew, chew. Food goes in the middle, but each one is a little different. So one's fully closed, one has 5 holes, so just a little bit of food comes out, and one has 10 holes. So it's really a nice way to introduce flavor, but make them feel safe that they're not going to choke or gag on it. There's also those mesh feeding bags and silicone feeding bags you see with kids. Some of the adaptable and equipment we like to use, there's the scooper ball, which I love because it's suction to the table. And if a child doesn't have that bilateral hand use, they can just scoop it up the side. We have scooper plates too. We have those easy peasy mats. Our favorite honey bears. Honey bears, if you're not familiar, are great because you can squeeze it to help start the flow of liquid. Cup drinking, I really try to avoid those spouted cups as much as we can because we really want to teach them to use a regular cup for the lip and tongue development we need. So there's all kinds of different cups that we use, different straws, different widths of straws, diameters of straws based on their ability to close their lips around a straw. In terms of spoons, we have our nice shallow spoons we like to use, our dippers, curved spoons to help kids just bring it to their mouth so they don't have to turn their hands. For some of our kids, and I'll let Kate address this more if she'd like, our built-up grip spoons. Also, some of our kids need some help. They can't grasp the utensils or spoons, so we have these nice little grip things we might recommend. And then the Nork. I love the Nork. It's a knife and a fork. So again, for some of our older kids who can't cut and can't hold a knife and a fork together, the Nork is great because it really does cut well. So some things to remember. Kaizen's my favorite word. It's celebrating those small successes and small steps. Like Trish said, it's just so exciting. Even if a kid will touch the food, we get so excited because that's a big step to them. We don't want to allow avoidance. We want them to have to do something with their presented food. Feeding for most of our kids, it's about trust and comfort. We want to read their cues and know when you can move ahead or when you might even have to take 2 steps back. Children thrive on routine and predictability. The fewer the surprises, the better. And then consider snacks for optimal nutrition. We don't always have to give every kid a goldfish as a snack. We want to think of mini meals. We want to try for a fruit, a vegetable, a protein, and a grain at each. And for some of the kids, as they're expanding their repertoires, you know, we might make that little refrigerator sign with, oh, here are the proteins you eat, here are the fruits and vegetables, and here are your snacks and grains, and give them the autonomy that day to pick one from each. You decide what I'm putting in your lunch bag. So they're in control, but you know you're putting something in that you're feeling good about. Encourage self-feeding and exploration. Remember, it's okay to play with your food. And for some of the kids, that's the first step. We want to make sure the kids are well supported and seated. And we really want to remember those controlled choices instead of yes, no questions. So it's not, do you want milk? Do you want to drink your milk with a purple straw or a green straw? And so those are the choices. And it really takes a lot of remembering to make those controlled choice presentations. Some of our favorite strategies are that sensory hierarchy. As Trish mentioned, the food chaining. And food chaining, we want to think about how slowly and we make those changes. So if we want to go from milk to a banana milkshake or a banana smoothie, you know, we'll give them the milk and then we might just put a little bit of banana in there and toss it up, or a tiny flavoring of banana yogurt. You really want to make those changes small for the kids. We like to offer an all done bowl for several reasons. One, the kid knows they've tried it, they're done, they don't have to ever see it again. And so it gives them, again, that control. It's their choice. Also, for some of those throwers, we use that bowl as they're starting to throw to redirect throwing behaviors. Really important to have the child be part of the family meal. We want to make sure there's something at the table that the child likes, as well as putting the rest of the family meal on the plate and working towards that child accepting the presence of the food and then exploring it, even if it's starting just the child serving the other family members. We want to follow that developmental sequence, especially with children with all oral motor challenges. We want to present foods multiple times. Research has shown kids sometimes take 25 exposures to decide if they like a food. And I always like to say, you know, you might present something and the kid makes a face, and we really want to encourage, it's not necessarily bad, it's just different. And with multiple trials, you really see them like getting used to and accommodating that flavor. And we really want to remember to turn distractors into reinforcers. So for those kids who need the iPad or the electronics in order to eat, they're really not actively involved in the eating in that way. So we really try to say, okay, let's start with taking a bite and then you get the device for 20 seconds. All right, we're going to work to 2 bites and then 20 seconds. So we can turn it around. So we've completed a whole meal and then we can get that reinforcer. Kate created this and I just love it. So I had to put it in. And so I finished saying Kaizen, really recognize those small continuous gains towards positive change for the better. Kate, anything to add?
No, I think you did a great job. I think it's really thinking about, when we think about feeding, it's really about a whole body experience, right? And it starts, as you mentioned, as you referenced, it really starts from understanding how the medical piece will definitely influence a child's behavior around meal times, and how there's all these other bits. I always call it, it's like that blooming onion that seems to have layers that go on for days, and how we can be thoughtful and mindful of all of those things and how it will impact the outcomes.